you the research that we've done around dental aerosols and dental aerosol protection, and how the FXFCD extraoral suction unit fits into that process as the best solution. This comes from over 40 years of air filtration experience. We've been in the business since 1979, come from the industrial and commercial air filtration spaces, medical, clean room, and we've developed this solution specifically to handle the dental aerosols problem. So what is the dental aerosols problem? The problem is that there are certain tools that are common and used in the dental practice today: ultrasonic and sonic scalers, air polishing, the water syringes, and air turbine handpieces that produce spatter and aerosol. And it's a very important distinction, the difference between spatter and aerosol. So spatter is typically defined as water droplets that you can see. They're larger than 50 microns in size. So you'll see the reference here that that spatter can get everywhere. It'll go all over the place and presents a housekeeping problem. But the aerosols are the really small particles that you can't see. And if the patient is infected with a transmittable disease, those particles can carry that disease. And examples include tuberculosis, influenza, and COVID-19, among some others. And this has been a problem for quite some time. Now, both aerosols and spatter have the potential to carry the disease. However, the aerosols are the most dangerous. The spatter that falls on the floor or other pieces of equipment or the patient can easily be cleaned up with a disinfectant. They're not airborne. You won't transmit. It won't transmit the disease as long as it's cleaned up, and there's really not much issue there. The biggest issue are the aerosols, the really small aerosols that remain in the air. They don't have enough heft or weight to fall to the floor with gravity, and so they remain airborne after the procedure, at least 30 minutes or longer. I've seen some studies that say up to 3 hours, but in a typical study, it's about 20-30 minutes. And the best way to combat those is by cleaning the air in that space. If you re-enter that space with a new patient, or you finish the procedure and you remove your mask, you're susceptible to breathing in those particles. And just to summarize again, it's those small aerosols that you can't see, that are airborne, that remain airborne, that have the ability to penetrate through your lung capillaries and enter your bloodstream. And they are between 0.5 and 10 micron. And as you can see here, the size of a human hair is 50 to 70 microns in diameter. It's below the ability for the human eye to detect. And you should be concerned with those particular particles. And, again, being in the air filtration industry, this is the stuff that we typically are most concerned about. So you need to do something about it. The American Dental Association, the CDC, NIOSH, and OSHA all recommend that aerosols be minimized. And there are certain states that are taking precautions, not allowing dental offices to reopen until they have done something about it, and not protecting yourself or your staff or your other patients could open you up to insurance liabilities and malpractice issues. So how do we reduce these aerosols? There's a few solutions. For your employees and yourself, you can offer barrier protection: masks, gloves, eye protection, and face shields, and those type of things. Although a face shield would not protect you from these smaller aerosols that are airborne that you breathe in. There is a pre-procedural rinse you can use that reduces the bacterial count in the mouth. It has been shown to reduce aerosol production. Not eliminated. The aerosol production is reduced fairly minimally. You can use intraoral suction, and it's recommended to use intraoral suction. However, those aerosols still become airborne, and you can see in some of these studies that intraoral suction doesn't do much to decrease the surrounding aerosols in the air as a result of these procedures. Extraoral suction is the other thing we're going to talk about, or high volume evacuator. That's been shown to be the best methodology for reducing these aerosols, and they reduce them by up to 90%. And then they also recommend HEPA and UV filtration. But if a typical HVAC system is not designed to support HEPA and UV filtration in the amount of filtration required to reduce those aerosols in the room at the rate that you need to reduce them. While they're still in the room and the air changes are taking place with your HVAC system, you are susceptible, and your other patients are susceptible to breathing them in. So what we want to do is capture those aerosols at the source as much as possible. And that's the difference between what we consider ambient filtration, which is what your HVAC system is doing right now, and source capture filtration. So in a source capture method, we're trying to extract from the source, the creation source, those aerosols, and run them through filtration before they escape and enter into larger breathing area. And your HVAC system or secondary ambient filtration will do a good job of eliminating those particles that escape. However, we want to reduce the amount of particles in the air that do escape. So we want to create a hood or a scenario where we're capturing at the source as much as possible. Now, in the dental industry, there's a lot of talk about suction. We use a salival ejector to, draw the extra saliva out of the mouth when we're doing a procedure, and remove other things from the patient's mouth, the fluids, to create a better working environment, a better scenario. However, air filtration and suction are actually opposites. So if you want to move more air, you need a bigger hose. And if you want to move less air but create more suction, you need a smaller hose. So if you look at your vacuum cleaner, for example, your vacuum cleaner may have a fairly good size hose on it, but it's not going to work that well at lifting particles off the floor unless you put an attachment which reduces the orifice size. So when you reduce that size, you're reducing the airflow, but you're creating more suction, if that makes sense. And we often use the example of a coffee straw versus a standard straw. You can't pull much fluid through a coffee straw, but you can pull a lot of fluid through a much larger straw. And you can't blow a lot of air through a coffee straw. The diameter of the straw makes a large difference. And it's the same thing with a vacuum cleaner versus an air filtration system. You want to move more air. And the suction is good for lifting particles, from in the mouth, in the case of a salival injector, from the floor or carpet in case of a vacuum cleaner. But once you have a little bit of distance so that you create a working area into the mouth, you lose the benefit of that suction, and you're better having more air filtration or airflow. So about HEPA filtration. Does the HEPA filter capture the virus? The answer is yes. The reason is that you may hear that the actual size of the virus is very, very small. It's between 0.06 and 0.14 microns. And that is true. However, the virus does not travel on its own. It has to be packetized, and it's packetized in aerosols. When we speak, we create aerosols. When we cough, we create aerosols. And during this dental procedure, we're also creating aerosols. And the virus travels in those aerosol packets. And the aerosol packets, again, with this process, are between the sizes of 0.5 and 10 microns. So we really have to think about it in terms of filtering those, being very efficient at filtering particles of that size range. And an H13 HEPA filter captures 99.95% of particles that are 0.3 microns or larger in a single pass. Now, it's important to understand that HEPAs are rated based on 0.3 micron because 0.3 micron is an especially penetrative filter size, or a micron size. So actually, if you look at the filter specs, the filters are very, very efficient at particles larger than that size, and then they're also efficient at particles smaller than that size. But because the 0.3 micron size is particularly pesky. That's the rating system used for filtration in general. So is having a more efficient filter better? So, an H13 filter is 99.95% at 0.3. So that's the typical N95 mask that you hear about. Then there's a H14, which is 99.99 or 97, and then it goes up from there. And the balance that is important to understand here is that there's a balance between airflow and filtration. We like to say that a brick wall is 100% effective at filtration, but you're not going to move any air through it. So if you're not moving the air and moving the air that contains those contaminants and filtering it at a rapid pace, then the filtration is ineffective either way. So it is important to properly balance a very efficient filter with best airflow practices. And that's what we're trying to accomplish here. There's also questions about UV filtration and UV lights and viruses. So there's a large spectrum of UV lights, and it's very important to identify the proper UV light wavelength that is best at killing viruses. And viruses, not all contaminants are very affected heavily by UV lights. However, the UV germicidal lights are very, very good with viruses. It's proven to be extremely effective. And it requires minimal residency time, which is the amount of time the airflow moves past the light. And as long as the light is a germicidal UVC light focusing on 253.7 nanometer wavelength, then the effectiveness on viruses is very, very strong. What you want to stay away from is the other wavelength. There are two wavelengths in the UVC spectrum that are that produce effective materials, effective filtration properties. So one is on the lower end of the spectrum. It's at 185 nanometers. That particular wavelength is responsible for producing ozone. Ozone is, in many cases, used for sterilization procedures. However, it's harmful to breathe, and it's not very effective for viruses or germs in other capacities. What we do want to focus on is the light at the 253, commonly referred to as 254 nanometer segment, that does not produce ozone and, in fact, kills ozone, and also is very, very effective at killing viruses. So it's important that the UV light be sized properly for the airflow and that it produce the proper wavelength to combat these viruses. A little bit about the FX FCD unit by Fume extractors. So taking all those considerations at hand, we developed a system that we think is the best on the market. And it is the best on the market in terms of airflow. It's the best on the market in terms of filtration efficiency and filter size, because filter size does matter. And so we use those considerations to develop this system. We have a 3-inch arm, which is larger than most competitors. And we did that so that it allows more airflow. We provided a motor that is specific for airflow and less specific for suction, because that's how it's designed. The hood is designed for airflow efficiency. It's 8-inch round and transparent, so you can move, roughly between 6 and 8 inches away from the patient's mouth and still have the proper airflow and filtration that you need. The arm is specifically designed so it can stay out of the way of the procedure. It's very easy to maneuver in and out, and not have to worry about rearranging it or undoing a latch or a screw or something to put it into place. It has a control panel that features 10 variable speeds of filtration performance. The airflow is the best in this category. And obviously airflow is very important to us. It's 270 CFM on high at the unit inlet, and that creates 200 CFM on high measured at the end of the hood. So the spot at the hood is where we're most concerned about, and the hood design and depth affect the airflow performance as well. So it's very important to get that right. It's a 350 watt motor, and the UV light can be operated independently. We filter 5 stages, or we feature 5 stages of filtration. So it's important when you're developing filters that you go through stages. As we discussed earlier, it's important that the filters don't clog too soon because they will what is called face load, and they'll blind, and that reduces the airflow. That reduces the air efficiency, the effectiveness of the airflow, and clogs the filters, and then you're replacing expensive filters quite frequently when they're clogged with larger particles. So we go through stages. So the first stage is just a simple foam pre-filter. It's washable, it's small, it's designed to catch the very large stuff. So if a filling gets down there, or a rag or something, it will plug that, and it's easily washable and clean. So that's the really large stuff, the stuff you can see. The filter after that is a deep pleat moisture barrier filter. When it comes to filtration efficiency, the surface area is very critical. And that's why a lot of times you'll see pleats in a filter, because it creates these little pockets. And you can fit more surface area filtration in a smaller space if you pleat the filter media. So that's why we've used this deep pleat filter. It captures smaller particles that get through the washable pre-filter, but it protects the HEPA filter from those larger particles that are above the smaller micron range. So still stuff that we can see. It's effective for moisture because in this particular application, we're dealing with aerosols, we're dealing with moisture. We want to protect the HEPA filter from that moisture, and that's what that filter is for. We selected, of course, the H13 HEPA filter that's 99.95% efficient at 0.3 microns. It's much more efficient at larger micron sizes, and then smaller micron sizes, of course. And finally, we added a 6 pounds of activated carbon filter for odor and VOC filtration. And that's important because a lot of times when you're working on these fillings that are mercury and other things, it creates odors, and some of those odors and VOCs are also harmful. You want the carbon to be at the last stage because it does better. It has a longer lifespan if it doesn't have to deal with those larger particles and can only deal with the chemical related odors and VOCs. So that's very important as well. And finally, we have the UVC germicidal light. So anything that's really, really, really small that's passing through that HEPA filter, it's kind of a peace of mind. It filters and cleans and kills the viruses and bacteria that get through any of those other filters. Again, it's kind of a peace of mind last step effort, because we believe that the data shows that H13 HEPA is going to capture and eliminate the majority of that particulate that we're mostly concerned about. These units come with a 3-year warranty, and as I specified, a 350 watt, 40,000 hour brushless motor. And we chose that because it's just a very high reliability, low maintenance motor. We expect that you would get about 10 years out of that motor, if not 15, if you're operating it 8 hours a day, every day for that many years. Suggested maintenance schedule. So after every patient, we recommend you wipe down the fume hood and arm with a standard disinfectant. We also have a brush to clean out the first few inches of the interior of the arm. And you spray a disinfectant on that brush and use that. We can send you a video on that if you like. I would wipe down the entire arm with a standard disinfectant at the end of the day. Turn the unit on and spray some disinfectant through the arm, and then replace the filters based on the filter schedule. I would replace or wash the pre-filter every 2 months, replace the other filters once a year. We sell an annual filter changeout kit that includes 6 pre-filters and each of the other filters and a UVC light. If you have any further questions, please contact your salesperson. Thank you.